Hello, this is Dr. Kamel talking to you today about the question which was raised today in our um, lecture. So I want to explain to you briefly about the AV block or atrioventricular block, and then after that we will go to the question and try to answer the question again. So we will hopefully it will be simple and short as we can. So this is the electrocardiogram or the ECG, which we explained in our lecture that it starts with atrial depolarization, which is P wave, okay, and then followed by ventricular depolarization, which is a QRS, and we say that you cannot see atrial repolarization because it is here or happening at the same time as ventricular depolarization is happening. And then you have ventricular repolarization, which is a T wave. And as you know, we have different, intervals like the BR interval, which is important, and we will talk about, especially for the atrioventricular block. We have the QRS duration, and we have the QT interval, and so on. Okay, so for the B wave or the atrial depolarization, which is the first stage, followed by the BR interval, okay, and the time for the BR interval is a time for atrial depolarization and conduction from the sinoatrial node to the atrioventricular node. And it should be between 0.12 to zero point 0.2 seconds, about 3 to 5 small boxes. We explain that we have big boxes and small boxes. Okay, this is like a big box and small boxes 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Okay, and then for the QRS duration, we have ventricular, it should be 0.06 to zero point 0.1 seconds, and so on. So let's go to the first type of atrioventricular block or AV heart blocks. We have three main types. We have first degree heart block, which is just a delay in conduction, but it will happen. You went to take the bus to go to the university, you know, it is delayed, but it arrived late. You took the bus already, and you arrived to the university, and you took all your classes and attended your classes and so on. So there is a delay, but it happened or it will happen. Okay. Second degree heart block is partial block of the conduction. Partially blocked conduction is not a complete blocked conduction. And third degree heart block is fully blocked conduction. So first degree delay in conduction, second degree partially blocked conduction, and third degree is fully blocked conduction. Let's see the patterns here. So for the atrioventricular block, okay, let's we are concerned with the BR interval. We are concerned with the BR interval. Okay, so we said here that the BR interval should have, like a certain amount of time or certain duration. But here, the BR interval will be more than zero point 0.2 seconds, which is one large box or one big box. So, first degree heart block is disease of the atrioventricular node, and it is just a delay, but it will happen. Like each B wave is followed by a QRS. So B wave, QRS, T, okay, B, QRS, T, B, QRS, T. Each B wave is followed by a QRS and T. So there is some delay, but it is still okay. So this is seen also in athletes. So it could be physiological with increased vagal tone, you know, and generally will not progress. It is a benign condition. Okay, let's look at the second degree. For second degree heart block, we have two types, type 1 and type 2. Okay, so what happens here in second degree heart block? There is partial blocking of conduction. It is not a complete blocking of conduction. There will be increase in the time between B and the QRS time start, which means that there will be prolonged BR interval. So increasing BR interval before a QRS is dropped. Then the cycle is repeated. Let's look here. This is B, QRS, T. Let's look at the distance here from B to QRS is increasing. Okay, and then T, and then B, and increased distance here, and dropped QRS, and then resume of the pattern. Okay, so this is like expected pattern, like because you know that the BR interval are increasing, and then you will have a QRS, and then resume of the pattern. So this is type 1. This is type 1. Okay, so here, second degree heart block, one or more, but not all of the atrial impulses fail to conduct to the ventricles. We have two types. Type 1, they call it Winky buck, and type 2, they call it Moptis type 2. In both types, a B wave is blocked from initiating a QRS. So B wave is atrial depolarization is blocked from initiating ventricular depolarization, which is a QRS. Okay, so B, QRS, T, then look here, the distance is increasing. Look here, distance is increasing, and there is a, you know, here, and you have a dropped QRS. Okay, so type 1, also called Winky buck, BR interval gets progressively longer each beat until finally a QRS is dropped. A pattern can be described. You know the pattern, okay? So this is a disease of the atrioventricular node still, and the treatment is digitals. Let's look at second degree heart block, Moptis type 2. This is more dangerous, okay? BR intervals are constant. There is no prolonged increase in the BR interval as type 1, and QRS is dropped intermittently. You cannot expect when you will have a dropped QRS. So no pattern can be discerned. See, this is B, QRS, T, B, and the dropped QRS, and so there is no pattern which you can discern. Okay, this is a disease of bundle of His and Purkinje fiber. So this is not a disease of the atrioventricular node as types which we just talked about. This is a disease of the bundles of His and Purkinje fibers. Okay, and even the treatment is different, glycopyrrolate or intravenous isobutanol. Okay, so note that root QRS after the second here and the 6B wave in lead 2. First, second dropped, third, fourth, fifth, and the sixth. Okay. Third degree heart block. This is very dangerous. Okay. The atrial rate is independent of the ventricular rate. B wave and the QRS march out separately. They are not connected to each other. No relationship at all of the BR interval. The BR interval is constantly changing. The QRS is usually wide and bizarre because it is ventricular origin, So in this case, not the atrial depolarization or the B wave which created the QRS or the ventricular depolarization. No, it is independent. It was created by the ventricle itself. So let's summarize this. So for first degree heart block, there are delay or increase in the BR interval, but it is still benign. So continue exercise. Second degree, we have two types. Type 1, Winky buck, progressive increase in BR interval until you will have a drop in QRS. Just monitor exercise. Second degree type 2, which is MOPTIS type 2, there will be normal BR interval until sudden drop. This necessitates to stop exercise because it is dangerous. Third degree heart block, no relationship between, atrial contraction to ventricular contraction. Stop immediately and refer. So the heart block, if the R is far from B, then you have first degree. Longer, and then drop, then you have a winky buck. If some B's don't get through, then you have MOPS type 2. If B's and Q's don't agree, then you have a third degree. Okay. Let's look at the question which we have seen today in our lecture. A patient is undergoing a submaximal exercise test prior to beginning an outpatient cardiac rehabilitation program. Which of the following condition would not be an absolute contraindication to exercise testing? Someone who have acute pericarditis? No, I will not do any exercise for this one. Uncontrolled symptomatic heart failure? No, I will not do also any exercise for someone like this. Unstable angina? Yes, absolute contraindication. But for high degree atrioventricular block, here you can outweigh, the benefits versus the risk. Okay, this is relative contraindication for exercise testing. Exercise can occur with caution. Let's explain what's meant by high degree atrioventricular block. When we just talked, we said first degree, second degree, third degree, but we didn't mention anything about high degree atrioventricular block. So high degree atrioventricular block is a form of second degree, which is incomplete heart block, that can commonly be confused with third degree, which is a complete heart block. It occurs when there are two or more consecutively blocked B waves. This conduction disturbance can be particularly dangerous as it can progress to a complete heart block. So we have some sort of second degree heart block which can progress to third degree heart block. The anatomic region involved is almost always below the atrioventricular node, okay, as in MOPTIS type 2. So it is bundle of His or Purkinje fibers, okay, and the B to QRS ratio is 3 to 1 or higher. So for like 3 Bs and then 1 QRS and so on. And the ventricular rate is typically very slow. What differentiates high degree atrioventricular block from the third degree? We don't do any exercise for someone with third degree or complete heart block. Is that there remains some relationship between the B wave and the QRS complex. Still, there is some relationship. Okay. In other words, there is still some atrioventricular conduction which is taking place. Let's look at this ECG. B, QRS, T, then C, B, 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 and 1 QRS. So 3 Bs, 1 QRS. It should be, it should happen that after this B, we would have QRS, after this B would have QRS, after this, but this didn't happen. 3 Bs and only QRS. So this is what's meant by high degree atrioventricular block. Okay. In the slides which for the lecture which we were explaining, we said for the absolute contraindication to therapy, like angina, decompensated heart failure, patient who is unstable, and also chest pain with changes on the ECG. But here, I know that you are concerned about that. That's why you have asked it. Second degree heart block, but look at the next one, coupled with ventricular tachycardia. So coupled with ventricular tachycardia and third degree heart block. Okay, so that's why this was the answer for question for today, and some explanation for the atrioventricular block. So I'm hoping that it is I have explained that, and hopefully if you have any other topics you need explanation, you can send to us, and we will be happy to answer this explanation, either me or Dr. Blazer. So go studying, and best wishes for you all, and good luck. Thank you.